Thank you very much, Tom. The subject of this talk would be new mechanism understanding of the antiphospholipid syndrome. I promise you that we do not know exactly how these antibodies cause thrombotic complications. But first I have to say that I have no relevant conflicts of interest. I'm not paid by the industry, but only by the university. The antiphospholipid syndrome was defined in 1985 as a patient with thrombosis or a patient with recurrent pregnancy loss with persistently presence of antibodies in its plasma that react with anti-cardiolipin or that causes a prolongation of a clotting time. And by this definition, one suggests that these antibodies are also the cause of the syndrome. But at that time, we had no idea how an antibody that prolonged the clotting time could induce a thrombotic complication, nor we had any idea how antibodies against cardiolipin could induce thrombotic complications. And the latter was also not true because already 5 years later it was shown that the antibodies were not directed against the phospholipid cardiolipin, but they were directed against proteins, plasma proteins, that binds to negatively charged phospholipids. And although many different proteins have been identified, we now think that antibodies against beta-2-glycoprotein 1 are the important antibodies that causes this syndrome. And here you have also a crystal structure of beta-2-glycoprotein 1. You can see that it is built up of 5 different domains that are more or less the same as the complement factors, and that in domain 5, in this space-filling model, the positive charged amino acids are blue. You can see that in domain 5, there's a large patch of positive charge with which it binds to phospholipids. And based on these observations, in 2004, we updated the definition of the antiphospholipid syndrome, and one of the major changes was that the detection of the presence of anti-beta-2-glycoprotein 1 antibodies with an ELISA has been added to the serological criteria of the antiphospholipid syndrome, and this was published in 2006. But the inclusion of the autoantibodies against beta-2-glycoprotein 1 was not an unanimous decision. 2 members of the committee considered the existing evidence insufficient to justify the inclusion of anti-beta-2-glycoprotein 1 antibodies. And I must say, in all the studies performed, case cohort studies and other studies, the correlation between the presence of anti-beta-2-glycoprotein 1 antibodies with thrombosis and pregnancy morbidity is rather weak. So do we have obtained additional evidence after 2004 for the pathological role of beta-2-glycoprotein 1 in the antiphospholipid syndrome? And I think yes, we have. I think a very important paper came out last year of the group of Bruce Fury, who isolated patient antibodies specific for beta-2-glycoprotein 1, and he used this in a mouse model of thrombosis, and what you can see is that if you control IgG, there's only a weak response in this thrombotic model. But if you injected antibodies against beta-2-glycoprotein 1, specific beta-2-glycoprotein 1, you see the response on thrombotic complications is much stronger. And if you take patient with IgG depleted of anti-beta-2-glycoprotein 1 antibodies, the thrombotic response is not there. For me, indicating that beta-2-glycoprotein 1, antibodies against beta-2-glycoprotein 1 are important for the thrombotic risk. But how do we explain the weak correlation between the antibodies against beta-2-glycoprotein 1 in an ELISA with thrombotic complications? That can be explained by the fact that the antibodies against beta-2-glycoprotein 1 is a heterogeneous population of antibodies. And there are now many publications from different groups showing that antibodies against the first domain of beta-2-glycoprotein 1 correlates much better with thrombotic complications than antibodies against other domains. So if we measure anti-beta-2-glycoprotein 1 antibodies, we measure antibodies against all the different domains of beta-2-glycoprotein 1, while these studies suggest that specifically antibodies against the first domain of beta-2-glycoprotein 1 are the antibodies. And these antibodies have a high specificity but a rather low sensitivity for the thrombotic complications. And if you take the crystal structure, we now know that by site-directed mutagenesis, that specifically this area between the arginine 39 and arginine 43 here is the area where the antibodies seems to bind. But also this lysine 19 has been mutated and showed a lower affinity. And if you mutate these two amino acids, 8 and 9, then the affinity for the antibodies increases, indicating that here somewhere is the binding site of the antibodies. And if the antibodies bind in this area, apparently something happens, make an increase to thrombotic risk. Is that really important? Yes. There's one study done in which they have cloned specifically domain 1 of beta-2-glycoprotein 1 and used this as an inhibitor of thrombosis in an antiphospholipid model of a mouse. And if you inject IgG of a patient in this model, you see a strongly increased thrombotic response compared to control IgG. And if you then add domain 1 together with this antibody, you see that the response decreases, indicating that domain 1 can block the effect of these antibodies. If you mutate the arginine 39, which was considered as an important amino acid in the binding of the antibodies, so apparently the antibodies cannot bind, the thrombotic response is back. For me, indicating again that domain 1 apparently is an important factor in this disease. So I think that after 5 years, after the publication, there is now a significant amount of evidence that autoantibodies against beta-2-glycoprotein 1 are important players in the increased risk of thrombotic complications in the antiphospholipid syndrome. And that we have to realize that the autoantibodies against beta-2-glycoprotein 1 consist of various subpopulations of antibodies with different domain specificity, and autoantibodies against domain 1 seems to be the important ones for the syndrome. But this helps a little bit, but not everything. One of the things I always wondered about was that there were no circulating antibody complexes, antibody beta-2-glycan complexes in these patients. And also that the level of beta-2-glycoprotein 1 in these patients are similar in the patients than in controls. If you have autoantibodies against other clotting factors, you always see that the level of these clotting factors decrease tremendously. It binds to the protein and it is cleared from the circulation. Apparently, this does not happen in this syndrome. And we checked that further, and indeed, if you do the experiment and you coat beta-2-glycoprotein 1 on an ELISA tray, the patient antibodies do recognize beta-2-glycoprotein 1. But if you do it vice versa, you coat the antibodies on an ELISA plate and try to recognize beta-2-glycoprotein 1, so that if you isolate the patient antibodies and you want to bind beta-2-glycoprotein 1, you do not see binding. So apparently, the epitope for beta-2-glycoprotein 1 is not accessible in a normal situation for the antibodies. Only after you coat beta-2-glycoprotein 1 to a surface, it opens up and it is recognized by the antibodies. So we did some additional studies. But if you looked at the crystal structure that we solved a long time ago, this is the crystal structure. And you see this site here is defined as the antiphospholipid binding site. Here are the amino acids that I recognize. It's clearly visible. So how can this be a cryptic epitope if it's so exposed to the surface? So we wonder whether the crystal structure of beta-2-glycoprotein 1 really represents the plasma concentration of beta-2-glycoprotein 1. And it turns out not to be the case, because if we started to do electron microscopy studies together with a group in Lund, we observed that if you isolate plasma beta-2-glycoprotein 1 and you study that with electron microscopy, you see circles everywhere. But if you do that in combination with an antibody, you see here's the antibody, and here's the beta-2-glycoprotein 1, here's an antibody, here's beta-2-glycoprotein 1. You can see that beta-2-glycoprotein 1 has the same conformation as the crystal structure, while in plasma it's circular. So apparently, beta-2-glycoprotein 1 can exist at least in two different conformations, a plasma concentration, a conformation, and a conformation that is opened up in the presence of negatively charged phospholipids or in the presence of antibodies. And this is a monoclonal antibody. So that the conformational change could explain why beta-2-glycoprotein 1, in the absence of antibody, is not a risk factor for thrombotic complications and pregnancy morbidity, if you consider that opening up of beta-2-glycoprotein 1 is important for the thrombotic complications. And here you see again, this is atomic force microscopy. Here you see the circle, And here you see the open conformation. The question is, does this conformational stage help us to understand about the physiological function of beta-2-glycoprotein 1? And do we help to understand why these autoantibodies against this protein are so risky for thrombotic complications? We thought, well, to solve that, let us measure beta-2-glycoprotein 1 levels in different diseases. But of course we think that beta-2-glycoprotein 1 should have a function. We know that this function so far, no function has been identified, and that was predominantly based on the fact that patients lacking beta-2-glycoprotein 1 do not have a clear phenotype. But it is present in extremely high concentrations in the circulation. And it is highly conserved in mammals and vertebrates. And here's the crystal structure again, and we have made yellow all the amino acids that were conserved in all mammals. So these are present, these yellow amino acids are the same in all mammals, indicating that the protein is indeed very much conserved. So we think it's very unlikely that beta-2-glycoprotein 1 circulates in our body without any purpose. So we measured in different populations, and basically the level of beta-2-glycoprotein 1 in the normal population varies enormously. It goes from very low levels to extremely low levels, with a mean of about 200 micrograms per ml, which increases a little bit with age. But if you take different populations, you can see that patients with sepsis have about 1/3 of the amount of beta-2-glycoprotein 1 in the circulation as the normal population. And if we can find some patients back that recover from sepsis, you see that the level of beta-2-glycoprotein 1 increases. So apparently there was consumption of beta-2-glycoprotein 1 in certain acute clinical episodes, amongst other sepsis. So we were lucky that we were close to Amsterdam, where they have all kinds of studies on sepsis. But first we also studied the effect of sepsis on beta-2-glycoprotein 1. You see here beta-2-glycoprotein 1 as a circle. If you incubate beta-2-glycoprotein 1 with LPS-coated beads, you see that after interaction of LPS, it opens up. If you incubate it with beads coated with albumin, nothing happens. So apparently, if beta-2-glycoprotein 1 sees LPS, it induces a conformational change. And I said we were lucky that we were close to Amsterdam, where they injected volunteers, students with LPS, a low dose of LPS, and have all kinds of samples present after they have injected with LPS. And in these samples we measured beta-2-glycoprotein 1. And what was very striking, that immediately after injection of LPS in these volunteers, there is a drop of about 25% of the beta-2-glycoprotein 1 levels, and it stays low in time. If you take another protein with about the same molecular weight and about the same concentration, nothing happens. And if you take, for example, LPS binding protein, it stays the same level and goes up later on. So it's a very specific drop here in the beginning of injection of LPS in the beta-2-glycoprotein 1 levels. And if we study that further, the most important observation was that all these volunteers have an increase in temperature, and the increase in temperature is inversely related to the level of beta-2-glycoprotein 1 in the body. So patients with very high levels of beta-2-glycoprotein 1 had only a small temperature rise, while patients with low levels of beta-2-glycoprotein 1 had quite high increased levels of temperature. And the same, you can measure a number of things, and you will see this correlation also in all kinds of inflammation markers. So we think that beta-2-glycoprotein 1 is involved in the neutralization, amongst others, of LPS, and that this is a two-step process. LPS binds to beta-2-glycoprotein 1, beta-2-glycoprotein 1 undergoes a conformational change, and then is uptake of LPS beta-2-glycoprotein 1 complexes by monocytes via an LDL receptor family member. So we think that this is an important mechanism of an important function of beta-2-glycoprotein 1 in the body, but probably a function that he shares with other proteins, indicating why the few persons that has been described without beta-2-glycoprotein 1 do not have immediately a clinical phenotype. I must say that the binding site of LPS is conserved in the evolution. This is the antibody binding site. You can see that from human to Amarillo, it's exactly the same. Also, the phospholipid binding site is exactly the same. And the LPS binding site we've identified is completely conserved during the whole evolution of mammals and, in fact, of vertebrates. So indicating that it should be important because it's still there over a very long period. So we think that beta-2-glycoprotein 1 is a scavenger protein in circulation. It recognizes negatively charged proteins and cellular fragments and is subsequently cleared them from the circulation via members of the LDL receptor family. Does that give us a lead to the pathophysiology of the antiphospholipid syndrome? Is it so that the antibodies stabilize beta-2-glycoprotein 1 in an open conformation and that thus explain the clinical phenotype? It is possible, but we don't know. I always like this summary of the literature of the different possibilities, how in the literature published, how to have an explanation why these antibodies induce thrombosis. And you cannot read it, and I would not say, and that's good because there are so many different explanations, and I don't think that this is complete, but you can see that these antibodies seem to do a lot on different metabolic pathways, and that cannot be sure. So we have a problem. In contrast to the most of the indicated thrombotic risk factors, as said, the presence of antiphospholipid antibodies is a risk factor for all types of thrombosis. And is that so because the antiphospholipid antibodies disturb the hemostatic balance in more than one way, as I have shown in the first former slide, or is it so that the consequence of this presence of the antibodies is unique according to the disturbance of the hemostatic balance? I cannot give you a real answer. I think that the second one is the most logical one, and I think that there is now a general consensus that the presence of these antibodies resulted in activation of cells, in particular tissue factor. And this is a slide adapted from a recent publication showing that the antiphospholipid antibodies can apparently influence different cell types. It can influence endothelial cells, monocyte, platelets, and one of the things is the upregulation of tissue factor apparently in the cells or pre-activation of the platelets. But the important thing is that it induces a prothrombotic state, but that you need another second hit to get really the thrombosis. But the interesting thing is that apparently these antibodies in combination with beta-2-glycoprotein 1 can influence the cellular phenotype, and if antibodies or beta-2-glycoprotein 1 binds to these cells, then one would expect that it goes via a cellular receptor rather than binding to the membrane. And there is, I think, the biggest problem now at the moment, because we have identified many different receptors on cells that binds beta-2-glycoprotein 1 in complex with their antibodies. We have annexin A2, we have glycoprotein 1b alpha, we have LRP8, we have toll-like receptor 2, we have toll-like receptor 4, we have toll-like receptor 8. And interestingly, for all these ones are in vitro experiments, but also in vivo evidence for many of these receptors has been shown. That makes the situation a little bit complex. I will show you the results we have done, because we have shown that LRP8 was involved as one of the receptors for beta-2-glycoprotein 1. And we have done some experiments together with Sylvia Pierangeli. What we have done, we have cloned LRP8, the different binding domains of LRP8, and we have identified binding domain 1 as the interesting domain that binds beta-2-glycoprotein 1. And if we take a mouse model of antiphospholipid syndrome, so this is a control situation, if you injected antibodies against beta-2-glycoprotein 1, you see an increased thrombotic response, but if you do it together with binding domain 1 of LRP8, you see that this thrombotic response is inhibited, indicating that with this binding domain of LRP8, you can block APS induce thrombotic complication. That does not prove that LRP8 itself is involved. It can simply block beta-2-glycoprotein 1. So we did also some experiments with LRP8 knockout mice, and here you can see that in the normal mice control situation and injection of antibodies, if you patient antibodies injected in LRP8, then the response is much slower, much less than in the case of a normal mice, suggesting that LRP8 knockout mice are less sensitive for antiphospholipid antibodies. So we think that now beta-2-glycoprotein 1 in the circulation is harmless. But when it's opened up, for example by LPS, but can also be by other things, then beta-2-glycoprotein 1 opens up and can interact with many different receptors on cells. And we think that beta-2-glycoprotein 1 in this open conformation is stabilized when autoantibodies against beta-2-glycoprotein 1 are available. And then it can interact with different receptors, resulting finally in induction of many things, amongst other tissue factor, which we consider as a risk factor of thrombosis. How the interaction between the different receptors on the surface takes place, we have no idea, but apparently if you knock out toll-like receptor 4, you have a decreased thrombotic risk. If you knock out LP8, you have a decreased thrombotic risk. So apparently these receptors place together to activate the cells to induce the formation of tissue factor. I thank you very much, and I thank the people who helped me in these studies. Thank you very much.